This lecture is for the undergraduate dental students. The title of the lecture is Management of Transverse or Horizontal Discrepancies, given by Dr.Nadia, a lecturer and a specialist orthodontist. Normally, the maxillary teeth overlap the mandibular teeth both buccally and labially. But when for any reason the mandibular teeth, single tooth or segment of teeth overlap the opposing maxillary teeth, we say that we have a crossbite. So the crossbite can be defined as a discrepancy in the buccolingual relationship of the upper and the lower teeth during occlusion. We said that we have a buccal crossbite when the buccal cusp of the lower teeth occlude buccal to the buccal cusp of the upper teeth. And we said we have a lingual cusp when the buccal cusp of the mandibular teeth occlude lingual to the lingual cusp of the upper teeth. Sometimes we call it as a scissor bite or non-occlusion bite because there will be no occlusion between the upper and the lower teeth. The third type is the functional crossbite, which is usually associated with displacement. So when the patient occludes or close from the rest position of the mandible into the centric occlusion, he will encounter a deflecting contact. So he is going to displace his mandible either to the left or to the right or anteriorly to have the maximum intercuspation so that he can occlude, so that he can do the function of the mandible, just like the speech or mastication. So this occlusion, which is associated with displacement, are called the functional crossbite, the displacement. We can classify the crossbite according to the location in the dental arch as either anterior, if it was located anteriorly, whether including single tooth or segmented teeth, multiple teeth, or posterior when it is existing in the posterior segment of the arch, either it includes one tooth only or a multiple teeth, which is called segmental posterior crossbite. Also, it can be divided into buccal crossbite when the buccal cusp of the lower teeth occlude buccal to the buccal cusp of the upper teeth, just like we said before, and I am repeating this slide due to its importance. The lingual crossbite, the buccal cusp of the lower teeth occlude lingual to the lingual cusp of the upper teeth, which is also said to be a scissor bite. The posterior crossbite can be further classified on the presence of one or both sides of the arch. So if we have a crossbite on one side only of the arch, we say that we have a unilateral crossbite, whether it is buccal or lingual. When we have a both bilateral crossbite on both sides of the arch, we say that we have a bilateral crossbite, whether it is buccal or lingual. So in this case, the patient has a bilateral buccal posterior crossbite. In this case, we say that the patient has, we can see in this picture only one side of the arch, so I am going to say that we have a unilateral posterior lingual crossbite. This is a bilateral posterior lingual crossbite, and this is a unilateral posterior buccal crossbite. Also, the crossbite can be divided according to the structure involved, as skeletal, dental, or functional crossbite. I said that I have a skeletal crossbite when it is due to the malposition or malformation of the jaw. The problem is in the jaws itself, like for instance a maxillary retrognatism or mandibular prognatism or both of them, or sometimes a discrepancy in the anterior-posterior position of the upper and the lower jaws, like for a skeletal class 3 malocclusion. And I am going to explain the skeletal crossbite thoroughly in the next slide. The next division is the dental crossbite. I said that I have a dental crossbite when the problem is confined to the dentition only, but the upper and the lower jaws are in normal size and in normal position. Also, we have a functional crossbite when there is a presence of occlusal interference that lead to the displacement of the mandible either anteriorly or laterally to achieve the maximum intercuspation. For example, if the patient has incisor relationship that is edge to edge during occlusion, the patient will shift his mandible anteriorly to achieve the maximum intercuspation, so we will have an anterior crossbite. or if there is an interference between the upper and the lower canines or C's, the patient will shift his mandible laterally to achieve the maximum intercuspation, and he will have a buccal crossbite. Of course, we will have a shifting between the upper and the lower midline. So how can I differentiate between the skeletal and the dental posterior crossbite? Basically, by examining the width of the maxillary skeletal base, which is represented by the width of the palatal vault. This is done on the cast of the patient. If the base of the palatal vault is wide and the dentoalveolar process is leaning inward, which means directed inward, tipped inward, it means that the crossbite is dental. So, it is mainly caused by the distortion in the dental arch. But if the palatal vault is narrow and the maxillary teeth is directed outward or lean outward, but they are still in the crossbite, the problem is skeletal. So it is some sort of dentoalveolar compensation to the presence of a skeletal discrepancy. This constriction of the maxilla is compensated by the outward leaning of the posterior teeth, but they are still in the posterior crossbite. So we say that we have a skeletal crossbite. This is the cast examination. Now let us consider what is the etiology of the crossbite. The main causative factors of crossbite can be summarized as skeletal, dental, and soft tissue factors, and we are going to explain each one of them. The first causative factor is the skeletal. Generally, the greater number of the teeth that is involved in the crossbite, the greater possibility that there is a skeletal component of the etiology. A crossbite of the buccal segment may be purely due mismatch in the relative width of the arches or to an anterior-posterior discrepancy that result in the wider part of one arch occlude with the narrower part of the opposing arch. For instance, if we have a buccal crossbite of the entire buccal segment, they are most commonly associated with a skeletal class 3 malocclusion, and the lingual crossbite are usually associated with the class 2 malocclusion. The anterior crossbite are associated with the class 3 skeletal pattern, or sometimes the crossbite can be associated with a true skeletal asymmetry or asymmetry in the mandibular growth. All of the following to be a causative skeletal factor for the development of a crossbite. The first of all is the hereditary, as we said, the mismatch in the relative width between the upper and the lower arch, or the anterior-posterior discrepancy that is related to skeletal causes like the class 3 skeletal structure or the class 2 skeletal structure. The second one is the congenital, like the patient with a cleft lip and palate. So we will have a constricted maxilla. The result will be that the maxillary size is mismatched with the mandibular size. So we will have a buccal crossbite. Or if we have a trauma at birth, using the forceps during delivery will exert pressure on the TM joint. And this pressure will cause hemorrhage, fibrosis, and ankylosis of the TM joint. This will affect the normal growth of this sides of the TM joint on both sides. Or trauma during growth. The growing child, the most common cause for trauma during growth is riding the bicycle. Falling from it and traumatizing the jaw will result in the presence of a hemorrhage at the TM joint, and fibrosis and ankylosis, and retardation of the growth in the traumatized area. Sometimes we have a trauma after the completion of the growth, and we will have a malunion of the fractured segment, so we will have a crossbite on the affected side. Or habits, as we will see later. The habits, if not corrected appropriately at the appropriate age, will result in the presence of a skeletal crossbite. And we will see later how is this going to happen. The second etiological factor for the development of a crossbite is the soft tissue factor, that in most cases are associated with the presence of habits. Habits like thumb sucking, like mouth breathing, and so on, will result in the abnormality in the equilibrium forces inside the oral cavity. For instance, if the child sucks his thumb, It means that he will exert pressure from the lips and the cheeks. At the same time, the tongue will be lowered downward. So the pressure from the cheeks, the extraoral forces from the cheeks and lips will be more than the forces inside the oral cavity, the forces that should be exerted from the tongue when it fills the palate. And the result will be a constricted maxilla. The presence of constricted maxilla means that the width of the maxilla is less than the width of the mandible, so we'll have a buccal crossbite. The same goes for the mouth breathing. Also, when the patient will open his mouth means that the patient will lowering his tongue. So the tongue will not exert pressure on the palate that will stimulate the normal growth of the palate. The pressure from the cheeks and the lips will be more than the pressure exerted from the tongue, and the result is a constricted maxilla and a posterior or anterior crossbite. The third causative factor is the dental factors, and we have so many dental factors that may lead to the development of the crossbite. For instance, if we have anomalies in the number, in the size or shape of the teeth, like the presence of macrodontia or supernumerary teeth that lead to the lack of space within the dental arch to align them properly, or the premature loss of the deciduous teeth. So we will have a loss of space within the dental arch. There will be a decrease in the arch circumference to align the teeth properly, and so we will have a displacement of the permanent teeth into a crossbite position. Or if we have a delayed eruption of the permanent teeth, so we will get a loss of the normal space available for them. Or if we have an abnormality in the eruptive pathway, as we can see here, the canine is palatably erupted in a crossbite because they have an abnormality in the eruptive pathway. The treatment of crossbite is considered to be urgent, which means that we should treat the patient as fast as possible once it is diagnosed. For the following treatment of crossbite is urgent, which means that the patient should be treated as fast as possible for the following reasons. Firstly, the presence of uncomfortable occlusion due to the presence of displacing contact will predispose the patient towards the TM joint dysfunction syndrome because he is going to exert etc. pressure on the TM joint and the muscles. Secondly, the unilateral crossbite that is associated with mandibular displacement, as we said before, it is called the functional crossbite, will stimulate the asymmetry in the mandibular growth. So the patient may be converted from functional or dental crossbite into a true skeletal crossbite that is more difficult to be treated and takes more time. The third one is that the anterior crossbite, which is associated with labially movement of the lower anterior teeth through the supporting tissue result into gum problems like the gingival recessions, as we can see here in this picture. Finally, it has aesthetic consideration. It greatly affects on the facial appearance of the patient, and it is considered very unaesthetic for the patients. So what are the means of correction of a crossbite? We have different means to correct the crossbite, as using the tongue blade, especially if it is still developing. So the tongue blade is used to treat the developing anterior crossbite, which means that the upper incisors are still erupting. But when they are erupting into a more palatal direction. So that if they continue their eruption, they will be in an anterior crossbite. We can intercept this eruption by using the tongue blade, and it is put behind the tooth, and that is in a crossbite at an angle of about 60 degrees to the occlusal plane. The patient will exert force by biting on this wooden blade and using the lower teeth as a fulcrum to rotate the upper teeth into a more labial direction. A period of 5 to 10 minutes per day will be very enough to correct the abnormality in the eruptive pathway of the tooth, and usually the tooth will erupt into a normal position after a period of time. The second option is by using a bonded composite resin slopes. A bonded resin can be formed into an inclined slope and applied to the labial surface of each incisors to create a slope. So when the tooth will occlude with this slope, it will move labially, and so we can correct the crossbite. Another way to correct the crossbite is by using the lower anterior inclined plane, bite plane, or what is called the Catarines appliance, which is consisting of acrylic resin that is bonded to the teeth. We can bond it to the whole arch or only to the anterior segment. This slope is usually 45 degree, is made into a 45 degree with the maxillary plane. So when the posterior teeth will be in disocclusion, and when the anterior teeth will occlude with this slope, it will move its direction, it will give a more labially directed force to them, and we can correct the anterior crossbite. Or we can use the removable orthodontic appliances to correct the anterior crossbite. The common design to correct the anterior crossbite with a removable orthodontic appliance is by using an active component like the Z spring or the screw anteriorly. As we can see here, this is the Z spring and this is the screw. And we need a retention means, so we are going to use the Adam clasp on the 6s, Adam clasp on the 4s, or double Adam clasp on the D and E according to the case. Anteriorly, we will have an anterior component for retention, which is the Howley arch, and we need to use the posterior bite plane to open the occlusion. And it is mandatory, especially if the patient has an anterior crossbite with a deep bite. And finally, the acrylic base plate. And for the treatment of single tooth crossbite, we can use either T-spring or screw. And if we have multiple teeth, we can use a screw in the middle of the arch to expand the maxilla bilaterally. So the active component here will be the T-spring or the screw, and we will need a retentive means, which is the Adam clasp on the Howley arch anteriorly. Of course, we are going to use a posterior or anterior bite plane to open the occlusion and the acrylic base plate. If the patient was growing and he has an anterior crossbite due to constricted maxilla, we may consider using the face mask after the eruption of the incisors and the sixes, which is about 6 to 8 years of age. This face mask, with or without anterior intraoral expander, will stimulate the forward growth of the maxilla, and so it will help in the protraction of a retrognathic premaxilla and normalize the skeletal. And if the patient was still growing and he has got an anterior crossbite due to prognathic mandible, we may consider using another orthopedic appliance, which is the chin cup. The chin cup will rotate the mandible and redirect the growth of the mandible into a more posterior and downward direction. So it should be used carefully in a patient with an already increased lower anterior facial height. It may be used alone or it may be used with an intraoral appliance to expand the maxilla as well, according to the case. You may consider using the Frankel 3 myofunctional appliances, especially in a growing patient with a class 3 malocclusion due to retrognathic maxilla. This Frankel 3 has a labial lip pad. This labial lip pad will cause stretching to the periosteum and will stimulate the forward growth of the maxilla. Besides, it will counteract the action of the lips that may prevent the forward growth of the premaxilla. Also, it has a buccal shield. This buccal shield stands away from the maxillary vestibule, from the maxillary alveolar process. So it will stimulate the lateral growth of the maxilla and correct the posterior crossbite because it is at the same time in intimate contact with the alveolar bone of the mandible. So in this video, we can see that this patient has a skeletal class 3 malocclusion with anterior and posterior crossbite. He's going to be treated by using the Frankel 3 myofunctional appliance. The optimum wearing time is about 12 to 14 years per day. This Frankel 3 has upper labial lip pad and buccal shields. The labial lip pad will stimulate the forward growth of the maxilla, and the buccal shields will stimulate the lateral growth of the maxilla, so it is going to correct both the anterior and the posterior crossbite. And in some cases, we need to correct the crossbite by expanding the maxilla. So we have two options here. Either the dental expansion by using the slow maxillary expansion devices, and there are different types of appliances like the using of removable orthodontic appliance with a midline jack screw, The jack screw is usually activated by opening the screw quarter turn twice per week, and this will give us 0.25 to 0.5 mm of expansion per week, or by using the coffin spring, either removable or fixed, by directly bonding it to a band on the sixes. The coffin spring is activated by pulling the two holes of the appliance, or by using a special plier to activate the omega loop, or by using the quad helix expansion, either removable or fixed, by directly attaching it to a band on the sixes. This quad helix has four helices. The anterior one will cause posterior expansion, and the posterior helices will cause anterior expansion. And we are capable also of differential expansion, which means we can expand the right half more than the left half, and vice versa. All of these appliances, their main effect is dentoalveolar expansion. Another option is by using the skeletal expansion, by using one of the rapid maxillary expanders, such as the Hyrax. The Hyrax is essentially a dentofacial orthopedic appliance that produces its changes by splitting the mid-palatine suture. This is done by exerting an extreme forces to the palatine shelves. The underlying suture will split and result in a true skeletal changes. The Hyrax can be bonded directly on the fourths on sixes, or bonded to a composite resin with a posterior biplane, or can be attached directly by mini screws to the palatine shelves. The activation is done by turning the screw 1 to 2 quarter turn per day. So in each day we will have 0.25 to 0.5 mm of activation. When the mid-palatine suture will open, we will notice that we will have a midline diastema between the incisors, and we will continue the expansion until the lingual cusp of the maxillary teeth will occlude with the lingual incline of the buccal cusp of the mandibular molars. Then we will give the patient a period of retention of 3 months by using a removable appliance with an acrylic that is attached to the palate to retain our expansion, or sometimes we can use a transpalatal arch to provide retention if further treatment is being accomplished immediately. So in this video, we can see that the patient has got a constricted maxilla with a posterior crossbite. He is going to be treated by using the Hyrax. The Hyrax is attached to bands on the sixes. Also, a fixed appliance was used at the same time. The opening of the Hyrax is done by using a key, and we will get the expansion of the maxilla. We can notice the presence of midline diastema, which means that we have opened the mid-palatine suture, and the treatment will be accomplished by using the fixed orthodontic appliance. Another option is by using the three-dimensional expansion screw. Within this screw, we are going to have an anterior and posterior expansion at the same time. Also, the fixed orthodontic appliance can be used to correct the anterior crossbite and posterior crossbite as well, by using different mechanics, like by using multi-looped arch wire or by using the cross elastic. The cross elastic has multifunctions, according to the case. They can be tipped the upper teeth buccally and the lower teeth lingually, as we can see here from the picture, or it can be used to make the opposite movement of the teeth. If it was attached to the buccal surface of the upper teeth and the lingual surface of the lower teeth, they are going to tip the upper teeth in the lingual in the palatal direction and tip the buccal teeth in the buccal direction, and this will help to correct the posterior crossbite. If we have an adult patient with a severe maxillary constriction, we may consider using the surgical solutions. In the surgical assisted expansion, we are going to surgically splitting the mid-palatine suture and use the Hyrax to expand the maxilla. Or we can use the Lefort 1 osteotomy if we have a bilateral constriction and anterior retrognatism of the maxilla. The retention after expansion is really dependent on the amount of overbite. If we have an anterior crossbite with adequate overbite, there will be no need for retainer. But if we have an anterior crossbite with an open bite, the use of retainer is mandatory. Usually after the expansion, The posterior expansion of the maxilla, it is unstable, and we need to do overcorrection. We need to leave the expander in the same place for about 3 months to help to retain our results, and when it is removed, it should be replaced with the transpalatal arch until the end of the treatment. End of the lecture. If you have any question, please do not hesitate to contact me through the Google Classroom or through my YouTube channel. Thank you and best regards.